Hello dear students, I am Dr. Ruchi Raj, your original guru for Prosthodontics, and we are joined here today to discuss the questions of Grand Test 4 for the subject of Prostho. Without wasting any further time, let us begin. First question over here. The question says, which of the following is not an acceptable retraction method for making impressions of crown and bridge? Now we know that the methods of gingival retraction are generally surgical and non-surgical. Let us see what the options are. Option A is retraction cord. Option B, electrosurgery. Option C, burr and aerotor. And option number D is rotary curettage. Now, surgery and rotary curettage and retraction cord, all three of them, these are options, or rather these are techniques that have been used for gingival retraction. So, retraction cord, rotary curettage and electrosurgery, all of them have been used. The odd one out is burr and aerotor, and that is the answer. A burr and aerotor cannot be blindly used to do gingival retraction or removal of gingiva. Now, generally, the techniques for gingival retraction can be broadly classified into two types. Like I said, they can be surgical and they can be non-surgical. Under non-surgical, the one of the most common technique which we use mechanically and chemico-mechanically both is retraction cords. There are some other techniques also, such as copper bands and even using cotton twills and rubber dam and etc. Under surgical also, we have seen electrosurgery and rotary curettage. These are also techniques that help you reduce the bulk of inflamed or bulbous gingiva and simultaneously help you with retraction. When you look at non-surgical techniques, they either complete mechanically or with the help of a hemostatic agent, chemico-mechanically help you displace the gingiva so that you are able to record the finish line better, and then you are able to obtain proper details. After the retraction is done, the gingiva recoils back to its original position. But permanent damage to gingiva with the help of burr and aerotor and blindly just troughing and removing it is not an acceptable method of gingival retraction. Hence, option number C, burr and aerotor, is our correct answer over here. Coming to question number 2, which of the following impression material will distort the least when stored for 24 hours before pouring? So they are asking us an impression material with the least amount of distortion. So we are correlating the property of dimensional stability. We can also correlate and see which impression material has less polymerization shrinkage. Now the general thought that goes here is that any material that leaves a byproduct generally will not be that stable. So even if you know that much portion, you can still clinically correlate it and maybe you'll be able to solve this question. Now it is asking when stored for 24 hours before pouring the impression. Is it polyvinyl siloxane, polyether impression, impression compounds, copper band impression, or polysulfides? Now, out of all of these, I can give a very fair understanding that the answer would be from elastomers, considering that they obviously have better dimensional stability as well as reproduction capability than impression compound. So, if I were a student, I'll immediately cancel option number C out, that this would not be my answer. Coming to A, B, and D, polysulfides are good impression materials, but they are poor dimensional stability, will preclude us from using it in day-to-day practice. So even polysulfides are not the correct answer. The another important point with polysulfides which we can keep in mind is they even stain your clothes. Hence, that is one of the disadvantage of it. Now coming to polyvinyl siloxane and polyether. Now in PVS, it has not been mentioned whether we are talking of addition or condensation silicon. And when we compare dimensional stability of both of them, definitely PVS has excellent dimensional stability, excellent reproduction capability, but a direct comparison of two materials tells us that with polyether, you will have much better dimensional stability in comparison to polyvinyl siloxane. Hence, the correct answer here is option number B, polyether impression material. It is also said and very specifically written in textbooks under polyether that you can keep the impression for 24 hours and would be still able to pour this. Now, just a side thought over here. Why is dimensional stability extremely important? Because if the impression distorts, then the cast also, or the impressions replica that is produced in the cast will also be distorted. Hence, the entire process of prosthesis construction at that point will go wrong and incorporate more errors. Hence, dimensional stability is something which is extremely important. Also, as a side note, you should remember, ideally, impression trays that are made of cold cure resin should be made 24 hours before the procedure. Now, this is an extra edge or a mantra that I'm sharing here. Reason is that the acrylic also undergoes some polymerization shrinkage. No matter how good a material you are using, if the acrylic shrinks, then it is distorting that impression from that point. But if you have made it 24 hours before, whatever leaching of monomer or shrinkage that is bound to happen would have happened, and that will not happen later on. So you will have a uniform, even if distortion is there, you will be having a uniform distortion in that tray. And afterwards, when you're making an impression, the dimensional stability generally will not be affected. So that is the reason we say that we make it 24 hours before. Supposedly, I make it just before my procedure. What happens is, some parts of the tray may be thick, some parts of the tray may be thin. Now, the parts that are thick, those parts will shrink more because of polymerization shrinkage. So when they shrink at that point, they distort the impression at that particular point. Whereas the other point, the impression may not be distorted. This leads to an uneven impression. Hence, it is said that you pour it, or rather you make it 24 hours before your procedure. So this is an extra edge or a mantra that I'm sharing here with you, that 24 hours before your impression procedure, you should make your custom trays. Coming to question number 3, which of the following is not a mucostatic material? So it is asking which is not a mucostatic impression material, which means 3 of them are mucostatic. Agar-agar, alginate, zinc oxide eugenol impression paste, and impression compound. Now, basic knowledge about mucostatic impression technique says that it is also called as a pressureless technique, or is also called as minimal pressure technique. Mucostatic technique means that application of minimal to no load while making an impression is mucostatic technique. It is generally preferred for friable thin tissues or even damaged or abused tissues, so that you are not applying any excess load or pressure on tissue. Likewise, logic says that material would be something that will be not very thick or viscous, that the weight of that material exerts pressure onto the tissue. So if we look out of all of these, agar, alginate and ZOE are mucostatic materials, whereas impression compound is a very straightforward mucocompressive material. Even when we study mucocompressive technique, it is said that the application of mucocompressive technique is primary impression making with impression compound. Now there is an advantage of doing that. Why? Because the positive pressure that impression compound exerts on the tissue will help you register a good peripheral seal that is required for your primary impression and helps you make a better tray for your secondary impression procedure. So that is not bad. Having a mucocompressive technique is not bad, but there is a specific indication of it, and the material for it is impression compound. And coming to our question, since impression compound exerts pressure on the tissue while making the impression, correct answer here is option number D, which is your impression compound. Shade selection, question number 4. Shade selection is done within how much time? to avoid fatigue of the eyes? Now, I have solved this question once before also. I think I have solved this question multiple times in these live sessions. I think there's a video also of it, probably share on our Instagram account somewhere, where I have said that this is a question that even I solved when I was a student. Maybe someone senior to me would have also solved it. It is probably the granddaddy of all questions in FPD that you see. Shade selection is an extremely important topic in FPD. You cannot ignore it. Something is asked about it here and there. Either the temperature, either the time duration, either the light, either the seconds. Something here and there is repeated in a duration of 1 to 2 years. When we know that there are some topics like this, we try to learn everything about it. Now, coming to our question here, what is it asking? Is the original question of shade selection, that is a previous year question through last 20 years, is how much time is required for shade selection to avoid fatigue of eyes? Is it 5 seconds, 10 seconds, 15 or 20 seconds? Now, the reference to this question is 31st 4th edition, in which it is very clearly written that the time required for shade selection is 5 seconds. Anything above 5 seconds will fatigue your eyes and you won't be able to register the correct shade. It is specifically mentioned in your textbook because the color receptors of the eye are such that, because what happens is it will be having limitations with the color receptors of the eye. And the color receptors of the eye in turn are fatigue. So because of this reason, it is said that you have to finish your shade selection within 5 seconds. Now, for example, you are not able to do it. Then what do? You have to rest your eyes on blue or violet color in between your sessions of shade selection. Again, rest your eyes, clear out the fatigue, and then you can again process and start with your shade selection procedure. Now, generally, it is also said that shade selection should be done between 10 a.m. to 2 p.m. in natural full sunlight. And the light and the temperature for us is 5000 Kelvin. So these are the different things that are generally asked. We are also aware that there are 3 components of shade: hue, value and chroma. These 3 components of shade should be matched correctly, and then you can go further with your shade selection. So these are different questions that are asked from this topic, and it is a very important MCQ for your exam. Question number 5 is a clinical question. The bending of head forward or touching of the chin to the sternum while recording PPS is done in order to what? So when we do posterior palatal seal area recording, we will ask a patient to take the chin downwards towards the sternum, roughly at an angle of 30 degrees. Now, why do we do this? Prevent the entry of material into pharynx, activation of muscle of soft palate, activations of muscles of soft palate plus posterior wall of pharynx, and enhance it's not swelling actually, it is enhancing swallowing and deglutition. So what is the correct answer to it? The correct answer to is activation of muscles of soft palate, that is option number B. When we do border molding and final impression of maxilla, after recording all the limiting structures, we come to posterior palatal seal area. Posterior palatal seal area is the area that is present behind your tuberosity and between your tuberosity in a cupid bow shape, like this posteriorly, between your anterior and posterior vibrating lines. Now, this region harbors some of the tissues which have resiliency, over which you can apply some force so that there will be a positive pressure and you get a nice border or a peripheral seal. Now, the question here is slightly confusing for students because students feel that why A is not the answer. The purpose of recording PPS is to prevent entry of the purpose of recording PPS is to prevent entry of material into the pharynx. So that is the purpose of recording PPS. The purpose of recording PPS is also so as to get a good border seal, so as to increase comfort of the patient. But the question here is asking you, why do we do bending of the head while recording PPS? Now this bending is done so that you activate the muscles of the soft palate. They will come downwards and forwards anteriorly. So when the patient will bend the head forwards and then you ask the patient to swallow or do Vasalvas maneuver to record PPS, you are bringing the muscles down, and by swallowing you are activating those muscles. So the purpose of head forward movement that is there is only to activate the muscles of soft palate. This preventing the entry of material in pharynx or preventing the entry of material under the denture or helping with other functions that improve the comfort of the denture. These are advantages or roles of recording PPS. But head forward movement is only for activation of muscles of soft palate. If you feel that how do one prevent entry of material into the pharynx, it is by correct seating of impression tray. When you seat the tray posteriorly first and then anteriorly, any excess material will come out anteriorly only. Now this is also MCQ question to remember for our students is tray will always be seated posteriorly first and then anteriorly. So when you seat it posteriorly first and then you seat it anteriorly, any excess material will tend to come outwards and not go inside the pharynx. So option number A will correlate with the seating of the impression tray. But bending of it forwards is always activation of muscles of soft palate. Again, if you are still confused and have a doubt, you can put your message in the comment and a chat box below. We'll happy be to solve all of your questions. Question number 6, again from complete denture. Shunting effect occurs in complete denture because of what? If the occlusal plane is lower in the molar area, if the occlusal plane is lower in the incisor area, if the occlusal plane is lower in molar and incisor area, and when the patient has poor muscular coordination. Now, what exactly do we mean by shunting is that when there is an unfavorable tilt of the occlusal plane like this, what happens is there is a tendency that the denture will lose stability and either slide out or it can go backward also. Generally for maxillary denture, it can slide out of the mouth. For mandibular, it is said that it can go behind posteriorly. Now, the rule here is that if the occlusal plane is lower in the incisor area, then shunting effect is generally observed for maxillary denture. So, correct answer is option number B, like I have drawn here, that the occlusal plane is lower in the incisor area, hence you will see shunting effect of complete dentures. Question number 7. Again, a slightly controversial question for students and they do get confused over here. Flat or non-anatomic teeth are indicated primarily in what? Flat ridges, sharp ridges, poor muscular control, and well-contoured ridge. You may think that I can see more than one indication in the options. What do I choose? Remember my one tip for solving MCQ here. Read the question word by word. It says non-anatomic teeth are indicated primarily in what? The word of importance here which differentiates you from a very good rank and a good rank is this word which is primarily. If while reading you miss out on this word, you can select any random indication of it. But when you read this word, you have to find out that one indication of non-anatomic teeth, which is the absolute first indication of it. And luckily, in your textbook of Winkler, there is a straightforward line with this word only, where it says that flat ridge is the single best primary indication of non-anatomic teeth? And hence, the answer here is option number A, which is flat ridges. I'm not saying that some other options are not the answer of it, but primary indication is flat ridge, and hence it is the answer. So there you are also learning one clinical tip. Read your question carefully, see what it is asking. Sometimes the question tries to ask you, what is the one thing out of all of this? There you have to weigh in the options and see what is the best answer. It may not be possible that only one option is absolutely correct and other options are absolutely wrong. So there you have to see what is my best answer and accordingly select it. Question number 8. Denture fabrication for patient with Kennedy class 2 modification space 1 for mandibular arch and an intact maxillary arch. What occlusion is to be followed? Now, the things that one has to keep in mind is maxillary arch is intact. When maxillary arch is intact, it is going to already govern the occlusion of the opposing arch. What the status is, Kennedy class 2, that means distal extension on one side, and modification 1, that means maybe a tooth supported case on the other side. So this is the scenario in the mandible, and opposing arch is a complete complement of natural teeth. What occlusion are you going to follow? Is it going to be canine guided occlusion? Is it going to be unilateral balanced occlusion? Is it bilateral balanced occlusion? Or option number D, canine guided or unilateral balance depending on total number of missing teeth? Now, correct answer here is option number D. It can be canine guided or unilaterally balanced depending on total number of missing teeth. Now, before we try and understand the concept of occlusion here, one needs to know that canine guided occlusion means that when you are doing laterotrusion, only tips of canine come in contact and they disocclude all the other teeth. Canines are bearing the forces of stress that are created by laterotrusion, and it is done usually because the canines have very good long roots that help it bear it. When the canines are missing, then the entire brunt of that laterotrusion is taken by the teeth on that particular side. That is your group function or unilateral balanced occlusion also. Now here it has not been specifically mentioned whether canine is present or absent. If the canine is absent, you cannot give a canine guided occlusion. So for me, their option number A is out of the picture. Now, bilateral balanced, how it cannot be possible? Because on one side, we have a modification space. So, since the opposing arch is also a natural dentition, you won't be able to establish balancing. So, again, C is not possible. Now, coming to B and D. Why D is greater than B and a better option is because it has not been mentioned the total number of missing teeth. If canines are present, you can give canine guided in laterotrusion. If canines are not there, you can go for unilateral balanced. Hence, the option number D is the correct answer here, that either it could be canine guided or unilateral balance depending on total number of missing teeth. And that is your correct answer. Question number 9 is, stain removal commercial denture cleaners contain soda ash, sodium perborate, potassium perborate, and sodium hypochlorite. Now, straightforward DM question with fact-based answer. Option number B, sodium perborate, is the correct answer to it. Let us learn something about denture. Let us learn something about denture cleansers. Now, denture cleansers, if you see, generally consist of oxidizing agents. And generally, the two common oxidizing agents that are preferred, they are either sodium perborate monohydrate or you have potassium peroxymonosulfate. These are your two oxidizing agents. They even act as bleaching agents and remove the debris from the denture. Now, when sodium perborate is added into water, it will produce what? Can you put the answer in the comment box? What does it produce? So, when you add sodium perborate into water, it produces hydrogen peroxide. And because of this, it would be able to take out all of the debris and clean the denture. Hence, the correct answer is option number B, which is sodium perborate. Now, again, dental material based question, and I actually like this question a lot. Reason is that salts of Gontrez is a type of what? If I don't know anything or if I've not read it, I won't be able to assume anything here because salts of Gontrez could be anything. It could be an accelerator, it could be an etchant, it could be an adhesive, it could be a flux also. These are the questions that make or break your exam. And I actually pity the first time it came in exam because nobody would have probably able to guess correctly unless they have read it. So the correct answer here actually is that salt of Gontrez is a type of denture adhesive. It is a very good denture adhesive that is long lasting, less soluble, and it displays molecular cross linking. So, correct answer is option number B, which is denture adhesive. And that is the correct answer. Again, it is a previous year question. Similar to this, actually, there was a recent question, nest bit prosthesis. The question was nest bit prosthesis. Now, if you don't know actually what nest bit prosthesis is, you probably won't be able to attempt it. So, I consider these as very good PYQs. Someone who is not very thorough with PYQs will make mistakes over here, but if you are thorough, you won't be able to make a mistake here. That is why we even stress the importance of PYQs, that read your PYQs very well for the exam. Now, again, a very good question. Question number 11. See, why these questions are very important is they judge the entire concept via one question. And the question is that hinge transfer is compulsorily required. The word is compulsory in partially dentulous cases, completely dentulous cases, when increase in vertical dimension is to be done, or every orthodontic case. Now, we all know that hinge transfer is recording of hinge axis. So, when I view the mandible in a sagittal plane, there is an axis along which the mandible rotates. If I'm opening and closing my mouth right now, there is an axis that would, if this is my sagittal plane, there is an axis that goes through the sagittal plane along which I do opening and closing. Now, we are aware that when mandibular mouth opening occurs, for the initial few millimeters, there is pure rotation. So, there is a pure hinge movement. If this is the mandible and this is the hinge point of it, it just rotates around that hinge point. So, it will just move like this. Beyond that few millimeters of 20 to 25, it goes downwards, forwards and medially, and then it goes into translation. And that is how you achieve your complete mouth opening of 40-45 millimeters. Now, this particular axis along which mandible rotates is called hinge axis. And we do hinge axis transfer when we are doing face boot transfer in orientation jaw relation. And hinge axis transfer is required when we are doing changes in occlusion. We are re-establishing the occlusion. We are trying to re-establish the vertical dimension. We are correcting the existing occlusion of the patient. We are doing full mouth rehabilitations. All of these cases, you need your hinge axis transfer. That is absolutely essential. So, correct answer is option number C, when increase in vertical dimension is done. Do you think in other cases it is not required? It is, but you can still get away with it. Say complete denture, you are trying to do bilateral balanced occlusion, you would require hinge axis transfer either by an arbitrary face bow and then do mounting and so on for the process. But Without that also you can make a denture. But when you're reorganizing occlusion, because if I want to change the vertical dimension in the range of 2 millimeters on articulator, supposedly, I 100% need my hinge axis transfer. And that is why option number C is your correct answer over here. Again, students, I'll urge all of you, please put your queries or anything that are there in the comment box below. If there are any questions, I'll be most happy to solve them. You can even join our Telegram groups for further solving of your queries in future. Now, question number 12, linear curve. Linear means along a straight line. Linear curve running from anterior to posterior teeth is what? Curve of Spee, curve of monsoon, curve of, again, sorry, monsoon is mentioned. I would write Wilson over here actually. And option number D, Bonville's curve. So, what is the correct answer of it? The correct answer is, all of you might be knowing, answer is curve of Spee. I'll teach you something here in case you don't know. All of these curves are present in natural dentition, so as to introduce balancing in complete dentures so that the dentures have stability. We have curves that duplicate them. They are called as compensating curve. So in a denture, you will never have curve of Spee. You will have the compensating curve for the curve of Spee, compensating curve for the curve of Wilson, or compensating curve for the curve of monsoon in your dentures. But these are present in natural dentition, and something that runs from the tip of the canine posteriorly, that is your curve of Spee. Option number A is the correct answer. Question number 13. A patient was diagnosed with badly resorbed mandibular ridge, prominent genial tubercles at the crest of the ridge. What treatment would you consider? Denture with relief on intaglio surface, denture without relief on intaglio surface, denture with or without relief, and surgical intervention. Now, all of my students, I'm sure you are aware with anatomical considerations in mandible, you know genial tubercles are relieving areas. So very straightforward, option number B, without relief, and with or without relief are baseless options and you can cancel them out. Consider option number A and D. Now what do we keep in mind and what is the examiner trying to tell us here? Badly resorbed mandibular ridge. One thing what they are telling us, badly resorbed. Prominent genial tubercles at the crest of the ridge. Now, these will suggest indications of surgical intervention, and hence option number D is the correct answer. That when you see genial tubercles at crest of the ridge, when the ridge is badly resorbed, you would want to displace the muscular attachments of it down below so that the denture does not get displaced, they do not get interfered, they do not give a pain to your patient, and you need surgical intervention here. Since it is given in the option, that is why option D is the correct answer. And why do I say that? Because a similar question I have kept in the same paper, which is, if a complete denture patient has genial tubercle at the crest of the mandibular ridge, then what the denture base should do? Can cover them, should not cover them, should cover them but relief is not necessary, and should cover them and relief is a must. Now we understood again from the previous question, relief is necessary. So option number C is cancelled. Now other options, have a look at them. Can cover, should not cover, right? Should cover is something that we already know. So should not cover them is out of the question. You can cover them, or you can cover them and relief is a must. What do you think is a better description of the scenario? According to me, option number D is the complete answer of it. Here, the difference in the answer is that some options are partially correct, but not completely putting out all of the information. Like option number A is correct, you can cover them, but it is saying can, it is not saying should. And secondly, it is not talking anything about relief, whereas option number D is the complete answer of it, and hence that is the correct answer, which is it should cover them and relief is mandatory for it. So this is the correct answer of question number 14. Why did I include both of these questions? So you can compare and contrast and modify your answers according to how the options are given. Now with this, it brings us to the end of this session for discussion of GT4 questions pertaining to Prostho. Highlight Advanced Plus version 2, which has been launched. You all can join this particular plan. There's several advantages such as pre-recorded videos. You have an extensive errorless question bank. You have a very competitive test series where you can compare your performance with students all across India, and several other all features. You have clinical word, you have multiple 40 hours of clinical procedures. So you're not even lagging behind in your clinical work when you're taking a drop or time off for reading for these exams. These are several features of Advanced Plus version 2. I'm Dr. Ruchi Raj. If there are any queries pertaining to Prostho, please put them in our Telegram groups or on the comment box here, and I'll be most happy to solve them for you.